A term infant had seizures 24 hours after birth and was found to have episodes of hypoglycaemia. I am showing you axial and coronal brain T2 weighted MRI scans. Describe the findings.
Okay, I see it. The selected T2 weighted axial image at the level of the orbits shows marked bilateral hypoplasia of the optic nerves and the optic chiasm. On the coronal brain MRI sequence, there is complete absence of the septum pellucidum. This absence results in communication between the lateral ventricles, creating a characteristic flat-roofed single ventricle appearance. The pituitary stalk appears thin, and the posterior pituitary bright spot is ectopic, located at the infundibular recess. The cerebral cortex shows normal gyral pattern with no signs of migration anomalies such as schizencephaly or polymicrogyria. These features are classic for a congenital midline brain anomaly.
What is the diagnosis, and what is the pathophysiology of this syndrome?
The diagnosis is septo-optic dysplasia, also known as de Morsier syndrome. This is a rare congenital brain malformation characterized by a triad of optic nerve hypoplasia, midline brain abnormalities, and hypothalamic-pituitary dysfunction. The etiology is multifactorial, involving genetic mutations in transcription factors such as ASX1, SOX2, and SOX3, which are critical for early forebrain development. It is considered by some to represent a mild end of the holoprosencephaly spectrum, resulting from a primary defect in ventral induction.
Explain the clinical presentation, endocrine abnormalities, and visual deficits associated with this condition.
In that case, clinical presentation is highly variable, but neonatal hypoglycemia, seizures, and prolonged jaundice are common initial signs. The hypoglycemia is secondary to congenital growth hormone deficiency, ACTH deficiency, or central hypothyroidism due to hypothalamic-pituitary axis dysfunction. Visual impairment ranges from mild decrease in acuity to complete blindness, often presenting with nystagmus or strabismus. Diabetes insipidus can also occur due to vasopressin deficiency, presenting as polyuria and hypernatremia. A high index of suspicion is required in any newborn presenting with midline craniofacial anomalies and hypoglycemia.
Describe the associated brain abnormalities and the concept of septo-optic dysplasia, plus.
Well, septo-optic dysplasia is frequently associated with cortical migration anomalies, most notably schizencephaly. When cortical malformations such as schizencephaly, polymicrogyria, or heterotopia are present, it is termed septo-optic dysplasia plus. Therefore, careful inspection of the gray-white matter interface is vital to rule out clefts or gyral thickening. Kalman syndrome, characterized by hypogonadotropic hypogonadism and anosmia, is also in the clinical spectrum of developmental midline defects.
Discuss the management, genetic workup, and how you would manage this patient as a radiologist.
Okay. Management is highly interdisciplinary, involving endocrinologists, ophthalmologists, neurologists, and pediatricians. Prompt replacement of pituitary hormone deficiencies is critical to prevent adrenal crisis, severe hypoglycemia, and intellectual disability. Early visual stimulation therapy and support for special educational needs are also implemented. As a radiologist, I would recommend a dedicated high-resolution MRI of the pituitary and orbits and refer the patient to the pediatric endocrine team.